Welcome to This Week in Plastic Surgery. This week we're covering 9 notable papers spanning advancements in breast reconstruction and implant safety registries, contemporary management of peripheral nerve and vascular anomalies, and innovative technologies in microsurgical education and craniofacial surgery. Let's dive in. We begin this week with a deep dive into autologous breast reconstruction and safety tracking, starting with a critical look at how patient body composition affects outcomes in microvascular procedures. While a high body mass index has long been recognized as a risk factor for surgical complications, a retrospective study. Researchers in Finland analyzed preoperative computed tomography scans of 204 patients who underwent deep inferior epigastric perforator, or DIEP, flap breast reconstructions between 2018 and 2021. By calculating the skeletal muscle index, they categorized patients into 4 distinct phenotypes based on muscle mass and body mass index. Interestingly, they discovered that 29 patients, representing just over 14% of the cohort, met the criteria for sarcopenic overweight, defined as having a skeletal muscle index under 38.5 square centimeters per square meter and a body mass index over 25 kilograms per square meter. Complications occurred in 37 patients overall, representing about 18% of the study population. Sarcopenic overweight was found to be strongly associated with higher rates of early flap complications and overall complications compared to other phenotypes. In fact, in a multivariable analysis, sarcopenic overweight was the only significant factor associated with overall complications, carrying an 8-fold increase in the risk of overall complications. Neither sarcopenia alone nor overweight alone was associated with this heightened risk. This suggests that we must look beyond basic weight metrics and actively evaluate muscle-to-fat ratios when counseling patients and selecting candidates for microvascular breast reconstruction. When an abdomen-based donor site is not ideal or available, plastic surgeons increasingly turn to thigh-based autologous reconstructions. A comprehensive review in plastic and reconstructive surgery outlines the key indications, benefits, and anatomical nuances of these alternative donor sites, focusing on the gracilis myocutaneous, profunda artery perforator, and lateral thigh perforator flaps. The authors address common criticisms of thigh-based flaps, such as limited tissue volume and donor site issues like poor scarring, sensory changes, or delayed healing. By detailing precise anatomical landmarks, vascular pedicle dissection, and surgical refinements, the article provides practical strategies to optimize both the donor site appearance and the aesthetic outcome of the reconstructed breast, reinforcing thigh-based flaps as a highly viable, predictable alternative to the traditional DIEP flap. Deciding between these reconstructive options or choosing breast-conserving surgery has a profound and lasting impact on a patient's daily physical function and comfort. A longitudinal study published in Plastic and Reconstructive Surgery evaluated these differences using the BreastQ physical well-being of the chest subscale, tracking 517 patients with stage 0 to 3 breast cancer from their preoperative baseline to 1 year after surgery. The study compared 202 patients who had breast-conserving surgery, 125 who underwent mastectomy alone, and 190 who received mastectomy with immediate breast reconstruction. A change of 4 points or more on the scale was considered clinically significant. Surprisingly, despite starting with the highest baseline scores, patients who underwent breast-conserving surgery experienced the largest decline in physical well-being, dropping over 15 points from roughly 89 to 74. Mastectomy alone also led to a significant decline of nearly 13 points, dropping from approximately 77 to 64. In contrast, patients who underwent immediate breast reconstruction experienced the smallest decline, dropping by a clinically minor 3.7 points from 78 to 74. The investigators also highlighted the severe impact of adjuvant therapy, showing that radiation therapy led to an average decline of over 15 points, with those receiving regional node irradiation plus a boost experiencing the most severe drop of over 21 points, from nearly 89 down to 67. These findings underscore the importance of discussing long-term physical well-being and chest wall tightness with patients preoperatively, as immediate reconstruction may offer significant protective benefits for physical quality of life compared to other surgical pathways. Ensuring long-term safety for breast surgery patients also requires robust tracking systems for implanted devices, a need brought to light globally by the Poly Implant Prothesi recall in 2010. In response to the failures of standard electronic patient records to trace these implants, the Dutch breast implant registry was established. A landmark test recall study published in Plastic and Reconstructive Surgery evaluated the registry's efficacy by analyzing 1,113 implants in 726 patients who received devices between 2015 and 2019. The researchers compared the ability to trace these implants using electronic patient records alone versus combining those records with the national registry data. They found that adding the registry data significantly improved traceability, successfully identifying over 90% of the target implants compared to just under 81% when relying solely on electronic hospital records. Despite this success, 102 implants remained completely untraceable due to incorrect patient identifiers or missing data in both systems. This highlights a critical practice point for all plastic surgery clinics. The clinical utility of any registry relies entirely on the meticulous accuracy of the data we input at the point of care. Moving from the breast to the upper extremity, we addressed the challenging management of symptomatic hand and digital neuromas, which cause persistent, debilitating pain and functional loss after nerve injuries. Writing in Plastic and Reconstructive Surgery Global Open, researchers have proposed a pragmatic, anatomy-driven surgical algorithm to guide clinical decision-making. Historically, surgeons relied on passive strategies like burying nerve ends, but modern techniques have shifted toward active reconstruction. The author's algorithm prioritizes active reconstruction whenever a distal nerve target is available, utilizing primary repair or interposition grafting with autografts or allografts. When reconstruction is not feasible or no distal target exists, the algorithm provides structured, location-specific pathways for nerve end management and biologic targeting, such as muscle or bone transposition, tailored to the unique local tissue conditions of the hand. This structured approach helps streamline the evaluation and selection of contemporary surgical interventions for these difficult cases. In another effort to standardize complex clinical definitions, a systematic review in Plastic and Reconstructive Surgery Global Open examined the vascular anomalies associated with Maffucci syndrome. This rare disorder is classically defined by enchondromas and vascular lesions, but the medical literature has historically used highly variable and outdated terminology. By analyzing 265 articles published since 1950, the authors found that over half used the generic term hemangioma non-specifically, and only 2 articles correctly referenced the modern International Society for the Study of Vascular Anomalies definition, which specifies enchondromas presenting with venous malformations with or without spindle cell hemangiomas. Among 220 patients described in 183 primary reports, only 16% had a vascular diagnosis aligned with modern classification systems, and a mere 4% had venous malformations meeting the official criteria. Interestingly, 11% of patients presented with spindle cell hemangiomas in the absence of venous malformations, leading the authors to suggest that either lesion should be considered diagnostic for Maffucci syndrome. For clinicians, this study is a strong reminder of the importance of using precise, modern nomenclature to ensure accurate diagnosis, patient counseling, and interdisciplinary communication. Our final theme explores how new technologies and imaging modalities are reshaping surgical training, craniofacial planning, and aesthetic safety. In the realm of global education, the high cost of surgical microscopes remains a massive barrier for trainees in resource-limited regions. To address this, a team developed a novel, low-cost, 3D-printed surgical microscope, presenting their findings in Plastic and Reconstructive Surgery. Utilizing modified binocular objective lenses and a dual-mirror array, this portable device provides a fixed, 6.5 times magnification and near-field stereoscopic viewing. The 3D-printed chassis features an integrated light source that runs on standard or battery power. The prototype has already been successfully deployed for training in the United States, Rwanda, Ethiopia, and Vietnam, allowing trainees to successfully perform end-to-end anastomoses on tiny 2mm vessels. This innovation offers an accessible, high-fidelity training tool that could drastically expand microsurgical education worldwide. In craniofacial surgery, understanding the structural impacts of orthognathic movements is critical for long-term patient health. A retrospective study in the Cleft Palate Craniofacial Journal investigated how two-jaw orthognathic surgery alters three-dimensional pharyngeal airway volume in 27 adult patients with skeletal class 3 malocclusions. All patients underwent Lefort 1 maxillary advancement combined with bilateral sagittal split osteotomy mandibular setback, with computed tomography scans taken preoperatively and 6 months postoperatively. The researchers observed highly region-specific airway changes. While nasopharyngeal volume increased significantly by nearly 2,000 cubic millimeters, the hypopharyngeal airway volume saw a significant reduction of over 1,000 cubic millimeters. This hypopharyngeal reduction was strongly correlated with the degree of mandibular setback, particularly at point B. While these represent morphological rather than functional changes, they emphasize the need for careful preoperative airway planning, especially in patients with pre-existing sleep apnea or borderline airway dimensions. Finally, we turn to safety and aesthetic surgery, specifically focusing on gluteal fat grafting. Given the rare but catastrophic risk of fatal pulmonary fat embolism from accidental deep intramuscular injection, intraoperative ultrasound has been widely proposed as a protective tool. A scoping review published in the Aesthetic Surgery Journal analyzed 9 studies published between 2018 and 2025 to evaluate the strength of the evidence supporting ultrasound-guided gluteal fat grafting. The review found that ultrasound was primarily used to visually confirm that the cannula remained in the safe subcutaneous plane in real time. While no cases of fat embolism or mortality were reported in these studies, the authors noted that the current literature consists almost entirely of observational case series and a single systematic review, with no high-quality comparative trials. While intraoperative ultrasound remains a highly promising and logical safety adjunct, further comparative studies are still needed to firmly establish its clinical superiority and define it as a formal standard of care. If you only have time for one paper this week, make it the study on body composition and DIP flap complications by Kurtula and colleagues in plastic and reconstructive surgery. This paper is a true eye-opener for clinical practice because it demonstrates that evaluating a patient's muscle-to-fat ratio, specifically identifying sarcopenic overweight, is a far more powerful predictor of microvascular complications than body mass index alone, providing us with a highly actionable screening tool during preoperative consultations. Here are the key takeaways from this week in plastic surgery. First, evaluate candidates for autologous breast reconstruction for sarcopenic overweight, as patients with low muscle mass and a high body mass index face an 8-fold increase in microvascular complications. Second, counsel breast cancer patients that immediate breast reconstruction preserves chest wall physical well-being far better than breast-conserving surgery or mastectomy alone, especially when radiation therapy is planned. Third, when performing gluteal fat grafting, consider incorporating real-time intraoperative ultrasound to visually confirm subcutaneous cannula placement, keeping in mind that high-quality comparative trials are still needed to establish this as an absolute standard of care. Fourth, utilize national registries alongside local electronic health records to trace breast implants, ensuring meticulous and accurate data entry to protect patients during future device recalls. And finally, when planning two-jaw orthognathic surgery for skeletal class 3 patients, anticipate a significant reduction in hypopharyngeal airway volume that correlates directly with the magnitude of the mandibular setback. That's your roundup for this week in plastic surgery. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.